Hi, I'm Dr. Kenneth Snow, and it's my pleasure to be able to speak about CVS Health and our new approach to diabetes care, and particularly the role of the retail pharmacist in improving diabetes care. So, why aren't we moving the needle? Over the last couple of decades, there's been an explosion in the number of medications available to treat diabetes, and yet if we look at the National Health and Nutrition Examination Survey over the past couple of decades, what's striking is that there really has not been much of a change in the care for folks with diabetes in terms of their glycemic control, their blood pressure control, or their lipid control. The data shown here was from a recent publication in the New England Journal of Medicine, and essentially the number of folks who are reaching target for glycemic control, blood pressure, and lipids have not changed over the past 3 sessions of the NHANES study, and those are 4-year period, so over the last 12 years. And actually, if we look back over glycemic control, that hasn't changed over the past 16 years. So despite the fact that we have a number of new medications available, we don't seem to be doing a better job. So why is this? Well, further data from this shows that when we look at what folks are taking in terms of the number of medications, the number of medications that a person takes, or that the average person takes, has not changed over this period of time. So even though there's many new options in which particular medication has changed, the number of folks who are still taking one medication or the number of people taking 2 medications still remains about the same. And so that means that people are not getting adequate treatment to improve their glycemic control. So recognizing this, CVS Health decided to take a new approach to chronic care. And we have a significant opportunity because of our community presence. Now, folks are familiar with CVS in terms of the pharmacy, and yes, we do have over 9,900 pharmacies nationwide. But in addition, in terms of brick and mortar presence, we also have over 1,000 minute clinics, and we have our CVS Health Hubs providing chronic care services, and their numbers are just growing. And beyond just the brick and mortar services, we also, of course, have virtual services, our digital app, which has been downloaded tens of millions of times, and of course the ability to connect with folks through telephonic or email connections, and our certified diabetes care nurses providing care management. So as we thought about the role of the pharmacist, we recognized that many pharmacists are really not practicing up to the level of their license. We know that these are well-educated, highly trained professionals who understand a tremendous amount about medications naturally, but also about the chronic diseases that these medications are used to treat. And so what we have done is identified members who are at high risk, and we enable pharmacists to be able to do more with these members. So these are specially trained pharmacists at local CVS pharmacies, but we recognize that if you walk into a pharmacy, you know that most pharmacists are very busy, whether that's a CVS or any place else, any of our competitors. So and to be able to enable our pharmacists to be able to supply this support, we need to provide additional staffing at the pharmacist so that the pharmacist is doing this as part of their job and not doing it off the corner of their desk or off the corner of their counter, so to speak. They're able to do face-to-face and telephonic counseling, and they document every interaction. So this group of patients that they follow, which we refer to as a pharmacy panel, are able to come into the pharmacy, meet with a pharmacist, engage with the pharmacist, and help resolve issues that they may be having in managing their disease. We know that when we reach out, we have a 70% reach rate for patients who are identified, 75% engage, and the average engagement is 15 minutes. Now, when these pharmacists reach out, they're able to do this both face-to-face and also telephonically. They have a list of patients, this pharmacy panel, that they are aware of who need assistance. And then when that person comes in, they're able to address the issues that person may be having, or they can outreach by making a telephone outreach to that person. And in addition to the typical types of messages that can be provided and the types of assistance such as with medication adherence, they can also get at issues of medication effectiveness. Is the regimen they're on optimized? And we can take that one step further. And because we can identify what other services that person may need, such as are they due for screening exams, or is there an issue with another comorbidity that they may have, the pharmacist can also address those issues as well. Which leads me to the CVS Transforming Diabetes Care program. So recognizing the opportunity that we have, we realize that there is a tremendous amount that we can do to improve the care that people with diabetes receive. So first of all, we need to identify those members who need the assistance. And we have a tremendous amount of data about these folks. We know their prescription claims. We also know medical claims and lab results. We know A1C readings. We know information that may come from other sources, such as their blood pressure reading. And we are able to utilize all this data to identify gaps in care. So what should be occurring for a person with diabetes and what is not occurring. And as such, we can then prioritize those gaps through the use of AI so that the most important gaps are prioritized to be addressed through the most impactful channel as possible. We have an omnichannel approach to identifying the ways that we can interact with members, and so we want to make sure that we leverage those channels that are most impactful for the most important gaps, and for gaps that are less important, we can use less costly, less impactful approaches. And of course, the goal of this is to improve health by lowering A1C, lowering blood pressure, and making sure that people receive appropriate screenings and their comorbidities are managed. So as mentioned before, we have this omni-channel presence that allows folks to interact at the CVS pharmacy with the pharmacist, at the health hub or minute clinic, or through any of our virtual engagement platforms. So which gaps are we identifying? Well, we recognize that there are a number of things that we expect folks to do who have diabetes to keep themselves healthy. And we've grouped them into 5 categories. Number 1 is medication adherence. If people have prescribed medication and they're not taking it, then obviously it won't help. But medication optimization is also quite important. Are folks on the right medication, on the right dose? Are they on enough medication? As I related at the beginning of the talk, that one of the major problems with achieving adequate control is that folks are not being put on enough medication, even though there are many types of medications available. So this clinical inertia where people are not moved along in their care pathway to receive a medication regimen that's going to work leads to problems. We can recognize and address this. Naturally, we want to work with comorbidity management as well. And also self-monitoring the blood glucose where proven beneficial. So not everyone necessarily needs to monitor, but for those where the data clearly shows that people should be monitoring and will benefit from it, we want to make sure that they are. And then finally, we want to make sure that people are receiving screenings for the potential complications from diabetes so that if they do develop complications, they can be addressed as early as possible. Now, once these gaps are identified through advanced analytics, we can identify what is the best method of reaching out to that person. What is going to be most impactful? What is going to be the best use of resources? So for a high impactful gap, somebody not taking the right medication and not being adherent, we can reach out through the pharmacy panel, through the health hubs, as I mentioned. They may also get outreach through a text message or an email. But particularly that one-to-one, face-to-face interaction is going to, with a trusted caregiver in their neighborhood, is going to have a significant impact. Something much less important in the immediate care for that person, such as having an eye exam, they definitely need to be outreached to, but that may just be done through a letter or through a text message, since the immediacy and the importance of that is less striking. So when we've looked through the number of gaps with our average member, keeping in mind that folks are expected to do many things to manage their diabetes, what we find is the average number of gaps per member is over 3. Now, the most likely place to find a gap is in guideline-driven screenings. Folks don't get all the screenings they need. And we can help remind them of this. But in addition, medication adherence and medication optimization run about 40%. And these are areas, as discussed, that are highly impactful in improving A1C. Natural lifestyle management and comorbidity are equally important in maintaining people's health. And finally, monitoring blood glucose is not as frequent a gap as one might expect. Those who need to be monitoring, most of those folks are actually monitoring. So for those who need an outreach and face-to-face, what we find is just over 60% shows an interaction with a care coordinator. Almost 60% shows an interaction with at the CVS Pharmacy, and 55% at CVS Health Hub. Obviously, this comes to more than 100%. Some folks will interact with more than one type of care provider, which of course helps to reinforce the message that's given, and keeping in mind that all these interactions are recorded so that one builds upon the other and reinforces the other. So finally, the question is, does this help? Now, if you think about it, over the course of time, gaps will close. New gaps will open, but old gaps will close. People who need to have a screening test will go and get it. Maybe they heard a commercial on TV. Maybe they spoke with a doctor. For whatever reason, they have gone and they've gotten that screening test, and the gap has closed. It would have closed with or without the program. So for us to assess success, we need to know, do people in the program close more gaps than similar types of people who are not in the program? So through the wonders of analytics, we've developed a control group who are not in the program, looking at what happens to their gaps over time versus similar folks who are in the program. And what we see is that there's almost a 10% incremental gap closure rate for those who are in the program. So we know that these closure gaps is not occurring just because of the passage of time or because of something outside of the program, but because of the impact of the program itself. So I thank you for your time, and am happy to hear your questions and to discuss further about our program. Thank you.